Morning. For those of you who don't know me, my name is Renee Bradley, and I'm one of the fifth-year emergency medicine residents here in Ottawa. And today I'm very excited to talk to you about bariatric surgery complications in the emergency department. These are patients we see fairly often, and I know personally I often struggle to think of a differential diagnosis other than an internal hernia and send these patients for a CT. Today, I hope to convince you that we don't need to send all of these patients for a CT and that there are a wide variety of complications. First, let's go through a few cases. You're in the emergency department and you see a 30-year-old female who has had a gastric band surgery 10 years ago. She has severe epigastric pain and has intractable vomiting. You're concerned that there might be an issue with her band. What's your next step? Will you send her for an abdominal X-ray, a CT? Maybe you just decide to call general surgery for their opinion. Then you see a 70-year-old man presenting with palpitations. He tells you he's had a successful roux-en-y procedure 5 years ago. His ECG shows that he has new atrial fibrillation and you'd like to start him on anticoagulation. He tells you, however, that his surgeon told him his gastric bypass can significantly alter the absorption of many drugs. Which anticoagulant are you going to start? A DOAC, warfarin, maybe you decide to refer him to thrombosis. Finally, you see a 40-year-old male who's 2 months post roux-en-y gastric bypass. He tells you he's been losing weight as expected, but he has episodes of abdominal pain and vomiting. He tells you he's heard internal hernias can be a common complication following this procedure. Should we be worried about an internal hernia 2 months after a gastric bypass? Today, I'm hoping to provide you with the tools to safely manage and work up these bariatric surgery patients in the emergency department. We'll do this by reviewing the most common types of bariatric surgeries that are performed. We'll then talk about the complications associated with each procedure and how to safely work them up using appropriate imaging studies. And spoiler alert, they don't all need CTs. And finally, we'll talk about other clinical considerations to keep in mind when treating bariatric surgery patients in the emergency department, such as medications and NG tubes. The history of weight loss medicine and bariatric surgery has dramatically changed over the years. The first documented bariatric surgery was during the 10th century. King Di Sancho of Leon was removed from the throne due to his morbid obesity. He was unable to ride his horse, carry his shield, or even walk. He was treated by a physician who sewed his lips shut, and these extreme measures did work, and he subsequently retook the throne. But we've come a long way from sewing patients' lips shut. In 1994, the first laparoscopic bypass was performed. These laparoscopic bariatric surgeries are becoming more and more popular. In part, this is due to their improved results and lower complication rates. As emergency physicians, we frequently see patients with metabolic syndrome and obesity. Globally, there's been a significant rise in obesity over the last 30 years, including in Canada. Obesity now affects more than 1 in 4 Canadian adults. Over 8,000 bariatric surgeries are performed per year in Canada, and these numbers are rising. Although the advancement of modern laparoscopic surgical procedures has overall decreased the rate of complications, the risk still exists. Generally speaking, bariatric surgeries can be divided into 2 main categories: gastric restriction and malabsorption. Gastric restriction creates a small gastric pouch and outlet. This causes early satiety and decreases food intake. The second type of bariatric surgeries are those that induce malabsorption. These procedures are designed to bypass segments of the small bowel. So in other words, surgeons are creating a controlled short gut syndrome. So let's talk about some of these procedures that are most commonly performed in Canada. These are the gastric sleeve, the roux-en-y gastric bypass, and the gastric band. So let's dive a little deeper into the details surrounding these procedures. Let's start first with the sleeve gastrectomy. This is the most commonly performed procedure in Canada and represents 58% of all bariatric surgeries in North America. During this procedure, the stomach is stapled, creating a long tubular pouch. It promotes weight loss by reducing meal volume and reducing appetite. Next is the roux-en-y gastric bypass. It promotes weight loss through both malabsorption and gastric restriction. The stomach is first divided into two pouches. The small, more proximal pouch of the stomach is then anastomosed to the small bowel, and this is called the roux limb, and you can identify it on this picture with the red arrows running through it. So when food travels down the roux limb, it bypasses the first section of your small intestine, leading to nutrient malabsorption. Finally, there's the laparoscopic adjustable gastric band. An adjustable gastric band is placed near the GE junction, which creates a very small stomach pouch. This band is inflatable and is connected to a subcutaneous port which can be accessed to inflate or deflate the band. Unfortunately, it has high rates of long-term complications and is no longer recommended in Canadian guidelines. At the Ottawa Hospital, approximately 600 bariatric procedures are performed per year. The majority of bariatric procedures that are currently being performed are the roux-en-y gastric bypasses, and these represent over 2/3 of these procedures. Sleeve gastrectomies are the second most common surgery, which represent roughly 15%, and the remaining 15% are revisions. Obesity Canada suggests the choice of 3 bariatric procedures: the sleeve gastrectomy, the gastric bypass, as well as a newer procedure called the duodenal switch. Notice again that gastric bands are no longer recommended. A duodenal switch is a procedure that essentially combines the gastric sleeve and a roux-en-y gastric bypass. The stomach is stapled, creating a long tubular pouch, much like a sleeve gastrectomy. It's then anastomosed to the small bowel, similar to a roux limb. It currently represents approximately 5% of the bariatric surgeries in Canada. At the Ottawa Hospital, however, only 4 of these procedures have been performed in total, but we'll likely start to see more of these in the coming years. So now that we've familiarized ourselves with the various surgeries, let's go through their associated complications. Starting with the sleeve gastrectomy. The 3 main serious complications that we might see are strictures, bleeds, and staple line leaks. All of these complications occur in the early postoperative period at a fairly low rate overall of 1 to 2%. The long staple line and sleeve gastrectomies makes it quite prone to bleeding compared to other bariatric surgeries. And what makes bleeding really unique in this patient population is that they tend to be extraluminal bleeds. So most bleeding occurs at the staple line from short gastric vessels. And as you can see in the picture, the bleeding occurs outside the stomach lumen. Often these bleeds develop into hematomas near the staple line, which can get infected. Signs of bleeding include hemodynamic instability like hypotension and tachycardia. They can also have abdominal pain and anemia. Given that the bleeding is mostly extraluminal, a CT abdomen with contrast is actually the most appropriate test to detect these, in contrast to endoscopy, which we use to identify most GI bleeds in the emergency department. And these are also usually managed surgically and not endoscopically. Then we have stenoses. After a gastric sleeve, the long tubular stomach is prone to stenotic lesions. Patients tend to present as you would expect with very classic obstructive symptoms such as abdominal pain, vomiting, and inability to tolerate PO. In these severe cases, patients should get imaging in the emergency department, and the best test for this is a CT with PO and IV contrast. These can be treated endoscopically or surgically, depending on the severity and location of the stenotic lesion. At this point, you might be asking yourself, why oral contrast? Why am I talking about this? We very rarely use PO contrast in the emergency department when ordering abdominal CTs. But most bariatric surgery complications that we're going to talk about today require CTs with PO contrast. The contrast opacifies the stomach and the small bowel lumen and is especially helpful in identifying leaks and stenoses. It's important that on a CT rec, you let the radiologist know that you're concerned about a complication related to their bariatric surgery, and this will allow them to properly protocol their study, and patients will be given the PO contrast almost immediately before their CT so they can get a good detailed view of the stomach lumen. I also suggest that you let the radiologist know the type of bariatric surgery that the patient has had so they know what anatomy to expect on the scan. And finally, we have staple line leaks. Gastric leaks are the most feared complication of gastric sleeves due to its high morbidity. They tend to present within the first month after surgery. They can present with abdominal pain, fever, and tachycardia. Similarly to stenoses, these should be investigated with a CT using PO and IV contrast. In this picture of an upper GI series, you can see oral contrast leaking out of the stomach lumen. So overall, what can we take away from this patient population? In terms of imaging in the early post-op period, most will require a CT with PO and IV contrast. But what do we do about patients who present with symptoms multiple months to years after their surgery? I spoke to some of our bariatric surgeons here in Ottawa, and they had some helpful tips. Dr. Walsh is a bariatric surgeon at the Ottawa Hospital, and he stated that patients who are months to years post-sleeve gastrectomy can be considered to have normal anatomy and are very unlikely to have a surgical complication from their bariatric surgery. So to summarize, the three main emerging complications that we might see in sleeve gastrectomy patients are strictures, bleeds, which tend to be extraluminal, and a staple line leak, which all present very early after their surgery, typically within a few months. These all tend to have overlapping symptoms, but luckily can all be detected using a CT abdomen with IV and PO contrast. So in patients who are less than 1 year post-gastric sleeve with symptoms, have a very low threshold to send them for CT. However, in patients who are months to years post-sleeve gastrectomy, our bariatric surgery colleagues feel that from our perspective, we can consider them to have fairly normal anatomy, and their risk for an emergent surgical complication is actually quite low. So work them up as you would any other abdominal pain in the emergency department. And for some patients, that might mean not getting a CT at all. I also want to quickly point out that internal hernias are not a complication that can develop with this surgery, and it should not be on your differential. We'll talk about these a little bit later. Next, let's talk about gastric bypasses. In this section, I'm going to cover complications related to both roux-en-y and duodenal switches. Here, timing can actually help us quite a bit in differentiating the various complications. For example, anastomotic leaks tend to happen in the first few weeks after surgery, whereas internal hernias tend to happen months to years later. Stenoses and marginal ulcerations fall somewhere in the middle. Anastomotic leaks tend to present within the first 10 days after surgery. The best imaging test to assess this is a CT with PO and IV contrast. They can present with an array of nonspecific symptoms such as fever, tachycardia, hypotension, abdominal pain, nausea, vomiting, and even shortness of breath. But how can we use these clinical signs to help guide our pretest probability for a leak? There's not a lot of evidence on this topic, but we know from small retrospective studies that tachycardia with a heart rate over 120 beats per minute and respiratory distress are both predictors for a leak. But you might be thinking to yourself, tachycardia and respiratory distress in a post-op patient, this must be a PE. In fact, bariatric surgery patients are at a very high risk of developing PEs postoperatively. The risk of post-op venous thromboembolism is 2 to 3 times higher in obese patients. And this is the second most common cause of death in post-op bariatric surgery patients, with an incidence of 2% with the mortality rate of 30%. So how can we tease out PEs from anastomotic leaks in gastric bypass patients, or even in gastric sleeve patients? This is really quite challenging because there's so much overlap between the signs and symptoms of PE and a leak. They both present with tachycardia, dyspnea, fever, hypotension, and potentially chest pain. From speaking to our bariatric surgeons, they consider tachycardia to be a huge warning sign in the first few weeks after surgery. The take home here is tachycardia, especially with a heart rate over 120, in patients within the first 2 weeks after gastric bypass or a sleeve gastrectomy is a PE or a leak until proven otherwise. When a leak is on your differential, get a CT abdomen with PO and IV contrast. However, we should also be adding a CT-PE to this workup. From speaking to our bariatric surgeons, they suggest that we actually order both a CT-PE and a CT abdo in all of these patients given the high rates of morbidity and mortality associated with both of these complications. Now let's move on to anastomotic stenoses. Most of these present in the first few weeks after surgery, but can also present later. The stenotic lesions can occur at either anastomosis and each present with slightly different symptoms. Early stenoses of the proximal GJ anastomosis present in the first few weeks after surgery. They have very typical obstructive symptoms such as abdominal pain and vomiting, and these can often be treated endoscopically. Obstructions at the distal JJ anastomosis can have serious complications. And what's really unique in these is that patients tend to not have any vomiting at all. Instead, the biliopancreatic limb, which you see here with the green arrows running through it, dilates and can potentially perforate. Anastomotic stenoses can be investigated using an abdominal CT with PO and IV contrast. Marginal ulcers typically form on the proximal anastomosis, and these occur in 1 to 7% of patients. Half of them present within the first 2 months after surgery, but some can occur as late as 2 years later. They can have pain, nausea, vomiting, and even a GI bleed. And these do have, again, the potential to perforate. Typically, these ulcers can be managed simply with a PPI and educating the patient on avoiding NSAIDs and smoking. Occasionally, in severe cases, though, they do need a surgical revision. CT scans and upper GI series here aren't sensitive in detecting these, and the diagnosis is usually made by endoscopy. Now finally, so generally in the ED, internal hernias are the main complication we think of in gastric bypass patients. This is typically a late complication after gastric bypass because in order for this to happen, the patient needs to have lost a significant amount of weight. During their surgery, defects are created in the mesentery. As patients lose a substantial amount of weight and intra-abdominal adipose tissues, this allows small bowel to herniate through these mesenteric defects. So typically, a patient needs to be at least a year out from their surgery to have lost enough weight for this complication to arise. From speaking to our local surgeons, you can start considering it on your differential in a patient who's lost considerable weight 6 months post-op, but that would be exceptionally early for this to present. I also want to highlight again that internal hernias only occur in patients with gastric bypasses. It shouldn't be a diagnosis you're thinking of in patients who have had a sleeve gastrectomy or gastric bands. In terms of making the diagnosis, it can actually be quite challenging because small bowel can intermittently herniate through these surgically created defects. This leads to intermittent episodes of pain with potentially negative imaging studies. Abdominal CTs with PO and IV contrast are the best test to detect internal hernias, but it isn't really a perfect test. The CT may show nonspecific signs such as distended bowel or venous stasis. There may also be a characteristic mesenteric swirl sign with swirling of the mesenteric vessels or fat. The overall sensitivity of CTs to detect internal hernias varies quite a bit in the literature. Some studies report sensitivities as low as 56%, while others report sensitivities as high as 99%. Given that CTs aren't 100% sensitive in detecting internal hernias, and that the hernia itself can be intermittent, if you still suspect it despite a negative CT, you should consider talking to your local surgeon. They will sometimes admit these patients and bring them to the OR. So to summarize, the timeline after a gastric bypass can greatly help us in narrowing our differential in patients presenting with symptoms. The workup does slightly differ depending on the complication you're worried about. In the early stages, so less than a month after surgery, you should be worried about leaks and stenoses. A CT abdo with PO and IV contrast is the best test to investigate these. Also make sure to add a CTPE in any patient that's tachycardic or has any other signs of a pulmonary embolism. Marginal ulcerations are best identified by endoscopy and can present as a GI bleed. And finally, internal hernias happen years after a gastric bypass, after a patient has lost significant weight. You can start to consider this on your differential multiple months following their surgery. They should be worked up with a CT using PO and IV contrast. However, even with a normal scan, if you have a high suspicion for an obstruction, call general surgery. They might decide to bring them to the OR. Yeah, Dr. Pam? Mm-hmm. I spoke to, so this was a question from Dr. Pan. He was asking if I had a chance to speak to radiology and if they've had issues coordinating the contrast phase when ordering both a CTPE and a CT abdomen with both IV and PO contrast. I spoke to Dr. Amy Neville about this, and she made it sound like they've never had issues with radiology coordinating this, and they tend to be able to do both scans at the same time during the same imaging study. So it doesn't seem to be an issue, at least at our center here. Yeah, no problem. And finally, let's talk about gastric bands. As I mentioned before, we're going to be seeing less and less of these complications in the emergency department because bands are no longer recommended in Canada, nor are they performed at TOH anymore. Nonetheless, patients still have gastric bands from their surgery years ago. And the two most important and concerning complications we're most likely to see are band slippage and band erosions. Although both of these complications can develop fairly early after surgery, they can also develop months to years later. Band slippage is the most likely complication you're going to see related to gastric bands, and it's essentially a transprosthetic herniation. It can present both in the early and post-op period, as well as many years after surgery. Acute presentations of band slippage are rare, but they can lead to really serious morbidity. The herniated stomach may become strangulated and perforate. Patients may have nausea, vomiting, delayed satiety, slowed weight loss, as well as abdominal pain and chest pain. And luckily, this is a subgroup of patients where we can potentially avoid sending them for a CT altogether. Here, our trusty abdominal X-ray can actually be used as a screening test. Now, I know what you're thinking. We all know that abdo X-rays don't have the sensitivity to reliably detect bowel obstructions. In this case, however, we aren't looking for secondary signs of a bowel obstruction. We're actually looking at the band placement. A normal gastric band should look something like this on an AP abdominal X-ray. The arrows here point towards the gastric band as well as the port. The band should look like a radio-opaque bar a few centimeters below the diaphragm. It should also be lying at a diagonal angle to the vertebral column. This angle is often referred to as the phi angle. The phi angle normally ranges approximately from 5 to 60 degrees. The band should be pointing towards the left shoulder or the 2 and 8 o'clock position. Here we can see a normal abdominal X-ray with a normal appearing gastric band in the first picture and a slipped band in the second picture. In the first X-ray, the band is pointing towards the left shoulder as we would expect. With slippage though, the band is now pointing towards the right shoulder and is lying in a more horizontal position, pointing to 4 and 10 o'clock. This should raise a red flag. When measuring the phi angle in the first X-ray, it looks to be within the normal range of 5 to 60 degrees. In the second X-ray, the phi angle is clearly abnormal. Another X-ray finding that can also be used as a clue for band slippage is called the O sign. As the gastric pouch herniates through the band during slippage, the band can rotate along its horizontal axis, and this can give the band the characteristic appearance of the letter O. So what do you do if you diagnosed a slip band on an abdominal X-ray and you're in the community with no timely access to a surgeon? Your next step would be to deflate the band. The band is connected to a subcutaneous injection port by a long tube. You can think of the port as being quite similar to other tunneled catheters that we're more familiar with, like portacaths. Although the procedure of accessing a gastric band port is likely quite foreign to most of us, the steps are really quite simple. If you're comfortable accessing a portacath, you're more than halfway there in terms of deflating a patient's band. Generally, most ports can be easily palpated and successfully accessed, but some might be difficult to palpate and require fluoroscopy to identify its position. Another method would also be to use ultrasound to help you locate the port. Huber needles should be used to access these ports. Regular spinal needles are not appropriate to use because they could lead to a port leak. Huber needles are non-coring needles, which are recommended for all implanted ports. They're designed to have a 45-degree angle at the tip, which helps prevent shearing of a port septum. The Huber needles that we carry in our emergency department look similar to this and are used mostly for portacath access. So here's a short video demonstrating how to access a gastric band's port. For people at home, unfortunately, we're having some trouble with the audio, so I'm just gonna pull the mic towards the computer. I apologize if you don't have great audio. I'll send out the link with the video out following my grand rounds.
Sterile gloves. prep stick, 5 cc syringe, stopcock, Huber needle, and then just a draw up needle, Band-Aid, 4x4s, saline. All right, move to the patient. Have the patient in supine position, hands behind the head. Incision is typically here. The port is typically in the left upper quadrant if I was their surgeon, unless, and most surgeons would be in the left upper quadrant to put the port. Sometimes they may be down in the right flank. So just a good prep there. Back to the table. We don't want to get any air in the system, so that's what the saline is for, just to sort of flush out your syringe. So, no saline in there. Just rinse through. All right, so we're going to have the patient lift their head up in the crunch position. Pop, and you can see there's instantly rebound. You can relax. In a patient who's obstructed, you want to take out about 3 cc's. That should more than take care of things. This particular patient has only mild reflux symptoms, so I'm only going to take out a half a cc as an elective reduction. And then the withdrawal, hold the skin, pinch the needle as opposed to the hub, and pull.
So as you can see, deflating a band can be quite straightforward or intimidating. Sorry? No, he aspirated. So what you saw there was retraction of some of the saline, so he had to inject some of it back in, given that he only wanted to remove half a cc. In our case, it's entirely reasonable to aspirate as much as you possibly can. So I was saying, as you can see, this can actually be pretty straightforward, or in my case, I find this intimidating, but you know, I think this is something that's reasonable for us to do. Our local bariatric surgeons do recommend that we deflate these bands in severe cases, especially if they're not able to come see the patient in a timely manner. So now let's move on to gastric band erosions. Wall erosions occur in approximately 1% of patients. Similarly to band slippage, it can happen both early and late after surgery. They tend to happen due to an over-tightened band or irritation from the band. In severe cases, they can lead to perforation. So ultimately, these patients do require surgical consultation for possible band removal. Symptoms include loss of satiety, and this is the most common associated symptom, abdominal pain, fevers, and possibly signs of a GI bleed. They can also be accompanied by signs of a port infection. So if you notice cellulitis surrounding the patient's port site, have a very high index of suspicion for a band erosion. So how do we work these up? Unfortunately, here an abdominal X-ray is not a reliable imaging test in this case. The gold standard is endoscopy. However, given that we don't have great timely access to endoscopy, CT with PO and IV contrast is a reasonable alternative. Here we see a CT with PO contrast showing a gastric erosion. Notice that the lateral aspect of the band has eroded into the stomach lumen. There is contrast material and a tiny focus of gas in the band. So as a recap, the timing of post-surgery for gastric band patients doesn't help us much in narrowing our differential for the two most important complications, which are band slippage and band erosion. However, there is an opportunity here to avoid sending these patients for a CT. A plain AP abdominal X-ray is a useful screening tool to assess for band slippage. If you do diagnose a slip band, your next step is to call surgery and deflate the band. If the abdominal X-ray is negative, they may need an abdominal CT or endoscopy to assess for band erosion. So now that we've talked about the main surgical complications we might see in bariatric surgery patients, let's change gears and go over other factors we might want to consider when caring for these patients in the ED. Bariatric surgery patients have altered anatomy and physiology, which can have a big impact on our medication choices. For example, NSAIDs are a broad class of drugs that we commonly use for analgesia. However, their use is strongly discouraged in post-surgical bariatric patients. In fact, patients are often told to avoid taking NSAIDs indefinitely. They have the potential to cause gastric damage through two main mechanisms. Firstly, they increase gastric acid production, which increases the risk for erosions. Secondly, NSAIDs may cause direct irritation to the stomach mucosa. But how much damage can they actually cause? From small retrospective studies looking at patients who had undergone roux-en-y surgeries, NSAID use was confirmed to be associated with endoscopically detected complications like marginal ulcers. PPIs, on the other hand, as you would expect, were found to be protective in patients using NSAIDs with an odds ratio of 0.3. We also know from other small studies that bariatric surgery patients do use NSAIDs at home despite being told to avoid them. Yet, these patients seem to overall have low rates of complications related to their NSAID use. So can we say that long-term use of NSAIDs are unlikely to lead to a complication in patients who are post-bariatric surgery? No, I don't think so, but PPIs are certainly protective and small infrequent doses are unlikely to cause harm. The bottom line is occasional use of NSAIDs in bariatric surgery patients is likely safe. I think it's entirely reasonable to give a dose of Toradol to a patient you're treating for a migraine, for example. And our local bariatric surgeons agree with this. They suggest discussing the theoretical risk of NSAID use with these patients, and that if we're to start a short course of NSAIDs, to always prescribe a PPI along with it. Next, let's talk about anticoagulants. Anticoagulants are medications we're increasingly prescribing in the emergency department. DVTs, PEs, and atrial fibrillation are the most common condition for which we start anticoagulants. Typically, DOACs are our first choice, mostly due to their fixed dosing and the fact that there's no need for routine monitoring. You might be surprised, however, to hear the following statement from the Canadian Adult Obesity Clinical Practice Guidelines. They suggest avoiding the use of DOACs due to their potential for decreased drug absorption in gastric bypass patients. In fact, vitamin K antagonists such as warfarin are the preferred agents for long-term anticoagulation in post-bariatric surgery patients. Think of the last time you saw a patient with new AFib in the emerge who required anticoagulation. Did you consider warfarin as an option for this patient? The overwhelming majority of us will prescribe DOACs as our first-line anticoagulant. And as you know, DOACs are recommended as first-line in VTEs and non-valvular AFib. So what should we do with these patients if they require anticoagulation? It's important to understand that the anatomic changes from bariatric surgeries can have various consequences on a drug's pharmacokinetics. Firstly, multiple restrictive procedures by nature decrease a patient's caloric intake. So drugs like rivaroxaban are dependent on food for its absorption. Some surgeries can reduce the volume of gastric acid secretion, leading to a more alkaline pH in the gastric pouch, affecting drugs like dabigatran that are dependent on an acidic environment. The altered anatomy in the GI tract can significantly decrease the absorptive surface for various drugs, including anticoagulants. Research has shown that warfarin can be safely taken in bariatric surgery patients, although its absorption may be altered. However, the dose can easily be adjusted by monitoring INR levels, hence why it's recommended as a first-line anticoagulant in this patient population. The evidence surrounding DOACs is, however, quite limited. And up until only recently, there was no robust data looking at the efficacy of DOACs in a bariatric surgery patient. This study was published in 2020 in the American Journal of Cardiology, and the objective of the study was to compare the efficacy and safety of oral anticoagulants in patients with or without a history of bariatric surgery. They also compared the efficacy of DOACs and warfarin in bariatric surgery patients. It was a retrospective matched cohort study of approximately 31,000 adults with non-valvular AFib with or without a history of bariatric surgery. Outcomes were compared between bariatric and non-bariatric surgery patients. Secondary analyses compared warfarin to DOACs in the bariatric surgery cohort. When comparing only bariatric surgery patients, the rate of efficacy and safety outcomes were similar between patients receiving warfarin and DOACs. There was no statistically significant difference in the event rate of stroke or systemic embolism with a p-value of 0.65. And when looking at safety outcomes such as bleeding and rates of mortality, there also were no significant differences between DOACs and warfarin, with a p-value of 0.59. Based on these findings, the authors concluded that DOACs have similar efficacy and safety compared to warfarin in bariatric surgery patients, and that they're likely a reasonable alternative to warfarin. This is the largest study that currently exists comparing DOACs and warfarin in patients with prior bariatric surgery. So for anticoagulants, the bottom line is, although guidelines explicitly recommend vitamin K antagonists as the preferred anticoagulant in bariatric surgery patients, DOACs are likely a reasonable alternative. I spoke to Dr. Legal from our thrombosis department to get his input on this issue. And he stated again that warfarin typically is preferred over DOACs in bariatric surgery patients for long-term anticoagulation, but he doesn't expect us to be starting warfarin in the emergency department. He also explained that they do occasionally use DOACs in these patients, but they follow their anti-10A levels or thrombin time to monitor their activity. For patients with DVT or PE, we can still start them on low molecular weight heparin like we usually would and refer them to the thrombosis clinic. To finish off, let's quickly talk about NG tubes. So naturally, many of us may be uncomfortable inserting NG tubes in patients who have had bariatric surgery due to their altered anatomy and anastomoses that can potentially be perforated. In fact, many bariatric surgery patients might tell you that they've been told they should never have an NG tube. But is this an adverse event we should really be concerned about? This is a case report of a 57-year-old female who was 9 years post roux-en-y gastric bypass. She was admitted to the ICU for pneumonia, and during her stay, an NG tube was blindly inserted for enteral nutrition. She unfortunately died during this admission due to sepsis and multi-organ failure. Autopsy revealed that her death was secondary to a small bowel perforation in the roux limb of her gastric bypass. And these are images of her autopsy findings. So in this picture, notice the small hole in her small bowel. Although bowel perforation from an NG tube is devastating, there's very little evidence in literature describing its safety in this patient population, other than a few case reports like this one. So what should we do with patients who emergently require an NG tube? I spoke to Dr. Amy Neville about this, who's the medical director of the Ottawa Hospital Regional Bariatric Center of Excellence. And she gave me a few tips on inserting NG tubes. She reinforced that we should not hesitate to insert NG tubes in emergent situations and that bariatric surgery is not an absolute contraindication. The risk for perforation is highest in the early post-op period, and extra care should be taken during exertion. When inserting the tube, make sure not to push against resistance. And finally, the tube might lie much higher than in most anatomically normal patients. So don't be surprised if it lies around 35 centimeters. Dr. Walsh also suggested using fluoroscopy guidance in patients that are high risk for perforation. So to wrap up, bariatric surgery patients are certainly a complex patient population. I hope that today I provided you with some tools to safely and confidently manage these patients in the emergency department. Roux-en-y gastric bypasses are the most common bariatric surgery in our region, followed by gastric sleeves. Expect to see more patients with duodenal switches in the coming years. Although gastric bands are no longer performed in our region, some patients still do have gastric bands and may present with associated complications. Cater your approach to working up bariatric surgery complications according to the type of bariatric surgery and timing post-op. Gastric sleeve patients are very unlikely to have surgical complications 1 year post-op, and at this point can be considered anatomically normal from our perspective. Roux-en-y patients have varied complications, and the differential narrows considerably depending on the timing of their presentation post-operatively. In the first month post-op, consider gastric leaks and consider adding a CTPE to your abdominal CT if your patient is tachycardic. Internal hernias can only occur after a patient has lost considerable weight, so usually multiple months to years later. Finally, gastric band patients should all undergo a screening abdominal X-ray when presenting with symptoms to assess for band slippage. The pharmacokinetics of drugs can be altered in bariatric surgery patients. Although warfarin is suggested as first line in patients requiring long-term anticoagulation, DOACs are a reasonable alternative to start in the ED with appropriate follow-up. Avoid NSAIDs in this patient population. 1 to 2 doses of NSAIDs in the ED are likely safe in a well-informed patient. If starting a short course of NSAIDs, always prescribe a PPI. So thank you all so much for your attention, and I'll take questions at this point if anyone has any.